Good afternoon, ladies and gentlemen. If you have a chance, grab a seat. I think we'll get started. Welcome to the Woodrow Wilson Center. My name is Jeff DeBelko. I'm fortunate enough to coordinate our global health initiative and direct our environmental change and security program. It's my distinct pleasure to welcome you all to this afternoon session, a session I believe fifth in the series on maternal health that we have the good fortune to be hosting here at the center with our partners from the Gender Health and the Maternal Health Task Force and UNFPA as partners and supporters. USAID's Global Health Team have been terrific supporters, and for today's meeting in particular as well, Columbia University. So you will find that there are many hands making lighter, certainly on this topic. It's not light work, it's still a lot of work, but lots of folks coming to the table to discuss today improving transportation and referral for maternal health. This series has been one that I think has been very valuable for being focused and specific and practical, but also setting these issues in the larger research agenda, the larger policy agenda. And so we've been both kind of on the ground and in the policy realm and going between the two of those, which of course what we have to do. So it's our great pleasure to be hosting this session today, one that we are able to webcast, and so we welcome the folks watching online. What that means for us here in the room is when it comes to the Q&A time, my colleagues will bring you a microphone. If you could state who you are and state your question in the mic, then the folks online can hear as well. But I'm going to turn the floor over to Anne to introduce our speakers. And again, thank you all for coming. Look forward to the discussion.
Thank you, Jeff, and I'd like to welcome everybody on behalf of the Maternal Task Force at Engender Health. Thank you all very much for coming. I'd also like to acknowledge our partners in this series, the Woodrow Wilson Center, UNFPA, the amazing people at AMDD at Columbia University, USAID, and Julie Babinard at the World Bank, who's not here today, was also a really big help with us putting this together. For those of you who don't know, the Maternal Health Task Force is an entity which is funded by the Gates Foundation, and our mandate is to serve the maternal health community by, among other things, convening the community around technical and programmatic issues of importance, and also by stimulating dialogue and trying to build consensus within the community. As part of that mandate, we're co-sponsoring this series of public events on new and neglected issues in maternal health, and this event is the fifth in that series. This event is also a reflection of our mandate to try to bring in expertise and the viewpoint of allied sectors into the maternal health discussion. And the transport sector clearly has a large role to play in improving access to care during pregnancy and childbirth. As part of that mandate, I wanted to let you know that this meeting today is part two of something that started yesterday. We had an all-day, smaller technical meeting yesterday at which we had representation from both the maternal health community as well as a number of people from the transport sector. And the people who were at that workshop yesterday are here today, and some of them, I think they're almost all here today, some transport experts, maternal health experts, and we're hoping that they will contribute to the discussion. We're going to have three presentations, three different country experiences by our speakers, and then we're going to ask Patsy Bailey from AMDD and FHI to come up and give you make some general observations, but also give you a flavor of the discussion that we had yesterday at the workshop. So without further ado, let me introduce our first speaker. Our first speaker is Dr. John Koku Owenor-Williams, who is the East Regional Director of the Ghana Health Service, and he will be talking about experience in Ghana.
don't know how to start. Good afternoon, ladies and gentlemen. My name is Koko. I'm from Ghana, and I just want to share a few experiences with Ghana and as far as maternal health and our community-based health planning and services, which is simply called CHIPS, is concerned. Just a bit of background. Ghana, we had our independence in 1957, and health services were basically modeled on the British system with a focus on hospitals. Over the years, these services largely was provided to serve mainly the urban population, and the rural population was largely ignored. Basic health services model was adopted after independence. What happened in 1957 is that mostly our resources goes into building large hospitals in large capitals, ignoring the majority of the district. Then we moved to district hospitals. And then we realized that that was serving just a few number of population, basically about 30% of the population. And we move on to look at some sector reform. And after 1957, we expanded to build district hospitals and health centers. But the results after a number of years, 20 years, were quite disappointing. But then in 1977, the ministry, realizing the problem, had a policy that said that most disease problems that cause the high rates of illness and death among Ghanaians are preventable and curable if diagnosed promptly by simple basic and primary healthcare procedures. That a major objective of the ministry at that time will be to extend coverage of basic services to most Ghanaians. In order to provide this extent of coverage, it will be necessary to engage the cooperation and authorization of the people themselves at the community level. It will involve virtual curtailment of the sophisticated hospital constructions and renovation, and will require a reorientation and redeployment of at least some of the health personnel from hospital-based services to community-oriented services. So clearly it showed that we needed to shift now to the community level, where in Ghana at least over 70% of our population live. The problem at the time is that the majority of the people have no access to health services. Issues of financial access and geographical access, quality of care was a problem, community involvement was non-existent, gender equity was an issue, and efficiency in resource utilization was also a problem. In actual fact, our maternal and child and infant mortality were very, very high. So we developed what is called the CHIPS program, which is a community-based health plan and services program, which is a close-to-client health delivery system based on evidence from research from our popular research center, which is the Navrongo Research Center. That project was called the Community Health and Family Planning Project. It's basically to retrain and deploy health staff in communities. Community organization and mobilization was essential, and then utilizing all the traditional social support to be able to galvanize people to provide health services. And that, the impact was that it improved the impact of primary health care. In fact, services were gone up, and family planning was increased, immunization, treatment of minor ailments, etc. The indicators were good. And so the government and the ministry adopted this as a major strategy of the ministry of government for health service provision. CHIPS is basically a coverage plan that seeks to address inequities or inequalities to access in healthcare, especially in deprived regions, districts, and communities. So what it means is that just getting community health nurses, reoriented them, train them, and put them in village locations. Every CHIPS, we have what we call a CHIPS zone, and every CHIPS zone has about 300 to 3,000 population. That nurse will go around and provide health education, treatment of minor ailments, and also the major point is also referral of patients that are beyond his or her scope. We have some milestone in developing CHIPs. First, we have health services that have to work in a particular area. Like I said, we have to orient community leaders. We have to have what is called a compound where the nurse will live. These are mainly community health nurses who are trained 2 years and given some midwifery skills. Then that person is put in a community. We have to provide equipment, and then volunteers will have to be organized, which we call the village health volunteers and the village health committees that supervise and support the work of the CHO. Basically, this reform was aimed at two things. It is to actually have an outcome of increased health, improved health, reduced mortality, and decreased fertility. And of course, the mobilization of the community is very essential. And you can see that developing logistics and service mobility is very essential in the task that was designed. Like I said, the results has been very good, and so it is now a national policy in Ghana that CHOs are now placed in various communities in Ghana. Now, what is the role of the CHO in community, in maternal health? They provide home visits and counsel people, they see children. They also provide domiciliary maternity services, antenatal clinic care, and etc. They provide treatment of minor ailments, and one of the essential elements of this is that they also train traditional birth attendants and supervise them in the communities, which is very, very good. They also mobilize the communities in health education, health promotion. They work together with the TBAs in providing maternal services. And also, one of the essential elements of this program is the issue of transportation and communication, that CHOs have all been given communication, which is called the Motorola, the two-way Motorola system, that they communicate with each other and with the referral center. Now, let me look at some few case studies that we. In fact, Ghana, our estimated maternal mortality ratio is 451 per 100,000 live births. This is from the 2008 Maternal Health Survey. But there are indications in certain parts of the region and the country that we have rates as high as 800. As at 2006, our goal was to reduce MMR to 150 per 100,000 live births. But if you look at the indicator for MDG 5, which is giving us maximum of 54 deaths per 100,000 lives in 2015, it shows clearly that we are far, far away from achieving our goals. Of course, mainly the issues we deal, our main cause of maternal mortality are not different. Clearly, hemorrhage, sepsis, unsafe abortion, etc., are the main causes. But when you look at the three delays, particularly in the issue of referral, the major one is a delay due to lack of transportation and time spent in transit. Because most of our communities are rural, the roads are terrible, and the lack of affordable and appropriate transport vehicles and long distances to travel are the major concerns. In Ghana, we have a national ambulance service that supports the health service. Unfortunately, there is several fragmentation. We have a national ambulance service, which is handled by the National Ambulance Service Authority under the ministry. Then we have the facility ambulances managed by the Ghana Health Service, and sometimes you don't see them talking together. Then the fire service also have its own ambulance service. And of course, the private NGOs. But a lot of work is done at the community level, where there are quite a lot of innovations by various individuals and facilities in terms of referral. This is a major problem that we had to deal with in our environment, particularly the roads are very, very bad. So you can imagine referrals of this nature. And so communities over the years in some of the regions, districts, have developed systems of referral, which are quite primitive though, but that is what is available. And here you see how communities mobilize, and we call it the palanquin ambulance. Because that particular area, the vehicles go there only once in a week. You see vehicles on the roads only on Sundays. So from Saturday to Saturday, communities have to carry patients to the roadside to be able to catch a vehicle to get to the next level. Of course, we have our remote areas where mainly riverine areas that you have to use boats. The nature of bridges also sometimes in the remote areas create a lot of problems. And of course, that's the nature of the road that you see. And in many parts where I particularly work, the main transportation system is the use of the donkey, that is used clearly donkey cart to transport patients. Of course, the bicycle is also very important in the equation in these transfers, and the motorbike, etc., etc. One of the interesting things is also the use of the tricycle, which is durable, convenient for that particular facility in the particular district, and so that is also quite used. In emergencies, you see these kind of things very frequently, that any available vehicle that carry patients, things happen along the way. This is a case where a woman was being brought to the facility and had to deliver in the car. And these are very, very common issues at the district and the district level. The innovation was this tractor ambulance, which was the community came together, discussed the issues, and we had to innovate this, and this has become now a major referral system within a particular district called Kwanta district. And this has saved so many, many lives. Of course, this is linked up to a hospital where the hospital has an ambulance system that the CHO will call into the community health officer who will transport in that tractor ambulance and then meet them on because the road is terrible for the ambulance to go, and they pick. But the good thing about this is that there's always communication between the CHO and either the driver or the nurse accompanying, and the hospital where the maternity unit is. There's a communication that anything that is coming is communicated, and then the nurse, the staff will be ready for the patient, which is very, very, very effective. Now, so this is done, like I said, with a lot of discussion with the community and telling them what is happening, how women are dying, presenting the statistics to them, and then they also see the need to support. In actual fact, one of the innovations is that the tractor ambulance, when it's not working, is used by the community members to also till the land around their farms. So that also generates revenue to fuel the tractor in terms of referrals or in terms of transport, which is also very, very good. And this tractor is looked after by the village health committee, supported by the CHO. So that is quite interesting. The other innovation is that mostly the CHOs write their cell phone number in the antenatal card of the pregnant woman, and also given to the village health committees. So at any time that there's a problem, they can easily reach the CHOs. This is also very important, because sometimes getting to know what is happening in the community is a major issue. Now, in this particular district, the statistics are looking very, very good. In 1995, the hospital was recording averagely about 8 maternal deaths a month. And by 2006, the institutional maternal mortality was only 5 recorded, and still keeps going down. So that is also very, very good. Now, let me say that almost 2/3 of the ambulance used in this particular district are related to maternal and child health emergencies, even though sometimes you see them carrying people who have snake bite is very common in the area, and they are very poisonous snakes. So they do that, our children are convulsing, or there's cerebral malaria, or there's anemia, severe anemia. The ambulance also used, but majority of the cases are mainly to do with maternal and child health. Let me just quickly, I know I'm running out of time. We have done some rapid assessment in one particular region, and looking at referral system, looking at transportation, and the results are very good, because that positioned the region to also implement some measures to improve on transportation and referrals. You realize that we look at 25 chief zones, and realize that only 15 of them had referral registers. So issues of documentation is a problem that we have to be dealing with. We also realize that out of 18 of the 24 zones, CHO requests for transport. The request for transport is done through cell phone. Mobile phone penetration is very, very high now in that particular region. So it creates the opportunity for us to be able to communicate and know what is happening and do effective referral. But the major problem or challenge that is faced is the issue of whatever transport that they are using, whether it's a tractor ambulance, whether it's a tricycle, whether it's a vehicle, the issue of maintenance is huge because of the remoteness of the region and the fact that the qualified people to maintain this transport system they are not readily available. And of course, most of the roads are also not conducive for some of this transportation. I think I will end there.
Okay, great. Thank you. He left us hanging, so we can ask questions. Our next speaker is Subodh Satyawadi, who is the Chief Operating Officer of GVK Emergency Management and Research Institute in Delhi, who is going to talk to us about the ambulance service that he is running in India.
Thank you, Annie, and good afternoon to all of you, ladies and gentlemen. It's great to stand here in front of such a distinguished gathering. I thank you all for coming and thank Wilson Center for giving me this opportunity. Yeah. I'll share with you a project on emergency response and management services which we have implemented in India, which we thought is innovative in a sense that it is, although universal, but it is pro-poor, and the model has emphasis to improve quality and access to health care as a whole in our country. GVK EMRI is a non-profit organization. It is a CSR activity of GVK Group, which is a infrastructure major of our country. They operate airports, they operate highways, they run 5-star hotels, they have power plants, and this organization they have created to give back something to the society. What we have come out with is an integrated emergency response service that addresses the challenge of poor access to the emergency support. The service was launched on 15th August 2005 in the city of Hyderabad in the southern state of Andhra Pradesh of India. Over a period of time, this service has expanded to 10 states across the country, the states which you see in red, and 2 days back, another state, 11th state, this state of Chhattisgarh, has also come on board. Our vision is to reach out to each and everybody in the country, over 1 billion people in the country, and give them an assurance that we'll be there for you in case of any emergency. And we want to do it over a period of next 2 years. When we started with 40 ambulances and an emergency response center in Hyderabad, it was done completely by EMRI through its own resources, because we thought it's important to demonstrate what can be done. Only then you can create a buy-in by different agencies involved, more so public authorities. So after we implemented this for almost 6-7 months with 40 ambulances in the city of Hyderabad and demonstrated the success it can bring in. It can bring in the overall improvement in emergency situation, and more so health-related emergencies. We started talking to governments to scale it up to whole of the state. Presently in Andhra Pradesh, we operate more than 800 ambulances. After looking at the success in the state of Hyderabad, in the state of Andhra Pradesh, all other states also start coming to us to implement this project in their areas. So in 2007, we started this in the state of Gujarat, and over the next 2.5 years, we have expanded to 8 more states. Now, if it has to be done in such a large scale, public participation is necessary. It cannot be done by any single private agency. So the model we developed, all the direct expenses related to that state are borne by the government, and GVK-MRI as its CSR activity provides and funds for the leadership, innovation, infrastructure, processes, collaborations, research training, knowledge and quality assurance. Mahindra Satyam, which is a IT major, has worked out emergency response center application, which we have provided free of cost to all the governments. GVK-MRI leverages public resources and manages them to gain cost-effective results and those outcomes which serve the poor people. Before we started, the situation was, it is on the basis of a study conducted by us along with McKinsey, 75,000 emergencies were occurring in a day. 80% people involved were at the bottom of the pyramid. The deaths which were occurring, almost 80% was first hour of the incident. So there was a window of golden hour which had to be exploited by providing quick transport as well as quick pre-hospital care to save lives. 4 million deaths because of cardiac road accidents, maternal, mainly because of absence of 4As, access to universal toll-free universal number. People did not know in case of emergency where to call, what to do. Ambulances which could save life. Ambulances did not have proper equipment, life-saving equipment. Those were just like trucks or just mere transport vehicle. There was no affectionate care during the pre-hospital transportation. And since a lot of poor people were involved, whatever existed could not be afforded by them. So we tried to address to all these 4As. And we started with a vision to respond to 30 million emergencies and save 1 million lives. Using our innovative model of emergency response services under public-private partnership that provides emergency and pre-hospital care, and that too free of charge to everybody, irrespective of status, class, creed, or region. And we were very clear, we wanted it to provide best-in-class service at the global standards, and in our mind, we were clear that we can provide this through leadership, innovation, technology, and research and training. According to us, these are the 4 wheels of our ambulances. Integrated emergency management infrastructure of this program starts with a 3-digit 108 toll-free number which can be accessed through any kind of phone, whether it is a landline, mobile, GSM, CDMA. It is something like 911 of US. but we wanted it to be toll-free so that nothing is charged even if an unconnected person also has to call for this number. We designed emergency response centers which were modern and spacious so that the emergency response executives did not face the fatigue and also respond to emergencies in a calm, cool, and proper manner. We took help of GIS, GPS to locate emergencies and ambulances. We designed ambulances which were cost effective, but they had everything which was required to handle emergencies and save lives, which was appropriate for the context. We studied ambulances across the globe. We studied in the US, we studied in UK, Europe, but indigenized the same to have appropriate equipment, appropriate vehicle for our conditions, and that too at a low cost. And we emphasize on training of paramedics. Our EMTs, they are provided extensive training, and pilots, they are provided not only training in safe driving, in emergency first respond, and also handling the scene. We developed a process and protocol which had complete understanding and well-defined responsibility throughout the organization. Complete records of patient care are maintained in hard copies, in soft copies, in applications, and they are archived. Everything is logged. Whatever call is received is logged and accessible at a later point of time. Patient information on arrival is shared with the receiving hospital so that a complete database is available. And what many forget is follow-up. We built it into the system that after 48 hours we'll do a follow-up. 2 simple questions: feedback on service and what is the status of patient. By assessing the state of patient, we can count how many lives we have been able to save. We leverage technologies, and a very important thing that we have emergency response physicians in emergency response center also, which give continuous medical direction to the EMT at scene, and also we give pre-arrival instruction to the victim so that before the ambulance arrives, they can do whatever little is possible. I've discussed about training, so I'll not go into the detail here. Now, for delivering service at the global standards, we were very clear we don't have to reinvent the wheel. We must learn from the knowledge and technology base which already existed in the world, the best practices and research and training. So we went for collaborations with Stanford, Carnegie Mellon. We are certified shock trauma training center. We are certified American Heart Association training center in India. Now, if we look for impact, what it has been able to bring in, we operate one emergency response center for one state. That means on an average 40 million population is served by one emergency response center. If we compare with this US, it is 500,000. So it is almost 80 times bigger. We make this service available, and we assure every citizen of those 10 states, almost 500 million people, that wherever you are, you call us, we'll be there. And interestingly, a large population, 64% is rural population, and out of that almost 10% is tribal population. We assure there also the same assurance and security. We have trained almost 30,000 people, 20,000 of our own, and looking at it, governments also start coming to us that please train our doctors, paramedics in emergency care. So almost 10,000 people of government hospitals we have trained. We handle every day more than 11,000 emergencies. We have more than 2,700 ambulances, which make 4.5 trips every day. We have almost 17,000 people on board. We assure, as soon as we sign agreement and MOU with the government, we assure that within 4 months we'll start the service. We take 91% of calls in first ring, that is less than 2 seconds. In the state of Gujarat, we take 99% calls in less than 2 seconds. The Unified Communication Center or Washington DC takes 96% calls in 5 seconds. We reach in urban areas in less than 15 minutes and in less than 25 minutes in rural areas. It's important to know that although we are talking about all kinds of emergencies, including police, fire, and all kinds of health emergencies, but because the kind and demography of the population we serve, the focus is heavily on maternal health. And out of 8 million emergencies which we have handled till now, more than 3.5 emergencies are pregnancy related. And on an overall basis, 31% emergencies are pregnancy related as on date. We save every day more than 300 lives. Until now, we have saved close to 200,000 lives. If we compare the costs, per trip costs us between $12 to $15. If we compare with the US, one trip costs $600 to $700. Now, having compared these figures, I want to add one more thing. We learned a lot from US, we learned a lot from 911, and we are grateful to them for that. If we talk about the qualitative outcomes, the Government of India Research Agency has found it to be a historic landmark in the healthcare deliveries, overall healthcare delivery system of the country. Presence of this service has been able to build trust of people in health systems overall, because once we pick the person quickly, we provide affectionate care, we provide quick response, we provide pre-hospital care. The receiving hospitals are also under pressure to do the same. We have been able to increase the institutional delivery. In the state of Gujarat, it has gone up to 92%. And we have been able to reduce maternal mortality by 20 to 25% in different geographies. A very specific study done in Andhra Pradesh, we found that there is a reduction of 20% in maternal mortality, specifically due to presence of this service. And also, the Common Review Mission of Government of India under National Rural Health Mission has found this model to be suitable for replication across the country in any state. Some of the cases we want to do more with less for more and more people. There's one difficult childbirth assisted by our EMTs, a triplet born in ambulance, a baby girl who was abandoned by poor people was saved by us. There's a train accident, both legs were amputated. There's a small child, she had problem, and there's a case of Ahmedabad bomb blast where our people handled 64 emergencies in a matter of 1 hour. Heart-related case, old women, and some very difficult accident extrication cases. Our ambulances have those equipment also to handle such emergencies. During the ways, some awards and recognitions have also come our way. By doing all this, we want to reduce poverty and improve the quality of life. And we strongly believe that it can be done by caring, valuing, and respecting life, which we want to do through humanness and humility and our commitment to serve the people. And that is the culture we try to build, and we have been successful in building in our organization. And that is the satisfaction we drive by giving back to the society, giving joy, happiness, and hope to the society and everybody at large. Thank you so much for listening.
Thank you. Our next speaker is Dr. Victor Conde Altamirano from CARE, and he is going to talk to us about transportation and referral in Bolivia. It's okay. Is that it?
It's okay. Good afternoon. My name is Victor Conde. I'm so glad to be with you. And I'm trying to show some experiences in Bolivia. Bolivia is the middle of South America. This research was made in La Paz. If you look by the colors, La Paz has a green area that is lowland, almost sea level. The yellow area is valley, 2,000 meters above sea level, and the orange or brown area is highland, almost 4,000 meters above sea land. The biggest problem is just in highland. Our maternal mortality rate average with DHS 2003 is 230, but in highland is 345. This is La Paz, that has two sectors. El Alto is the highland, and properly La Paz, the city. We had 4 hospitals where we worked among 6 months with 8,000 mothers having their deliveries in these 4 hospitals. And with our settings, we had studies at 4 hospitals, accounting almost 75% of all hospital deliveries. We have calculated for 2001 that 37% of our maternal deaths were at our hospitals. Instead of, since 1996, we have universal insurance systems for mothers and newborns and child until 5 years old. And we were supposing that we had readily available maternal health care with short distance from homes to hospitals. About the methods, we used a combination of clinical and management-based criteria to define and include near-miss cases. We included severe hemorrhage, eclampsia and severe preeclampsia, sepsis, and obstructed labor and anemia with several criteria. We have used the concept of near miss that has received increased attention as a valuable complement to reviews of maternal deaths. You know the definition of near miss. Further, we subclassified the near miss cases as suggested by Felipe et al. Into two groups, depending on when the women fulfilled the criteria for near miss. We specially focused on the category of women with a life-threatening complication already upon arrival at hospital as in an indicator of pre-hospital barriers to emerging obstetric care. In our findings, we found that maternal mortality ratio in this research was 187, with hemorrhage, hypertensive disorders, sepsis, and obstetric labor. With these results, we were asking, why did we have these problems? This is a picture of La Paz and its rural area. You'll see that here is the urban area I was showing in previous slides. But if you see these lines, from here, for example, here we have Escoma. Escoma has a hospital with second level resolution. From here to La Paz we have paving roads. Then you don't have problem with almost 200 kilometers. You need only 1 or 2 hours to arrive to La Paz. An emergency can solve easily. But if we go up, we have another communities. Its name is Camata. From Camata to Escoma, we have only 40 kilometers. But you need almost 4 or 5 hours to transport women or a newborn with an emergency. There is our problem in our far rural areas. And what kind of vehicles we have? We have many ambulances, 4x4. Last year, our president gave to all rural areas almost 800 ambulances, 4x4. Depending on our departments, we need boats, we need maybe motorcycles, we need bikes. I remember the palanquin from Ghana. We saw many women, transportation with devices like palanquin. But the real problem is to maintain and assist with enough fuel for our ambulances. Many of our mayors are sensitive with this problem, and they don't help us. Because of our women universal maternal and neonatal insurance systems, we must have guaranteed all the enough money to pay for these incomes. But no, not always we have these incomes to guarantee our maternal or neonatal transport. Now we have many national norms. We have a norm for reference and return from last year. And 6 months ago, we are working with CARE Bolivia in a new project with USAID funds. And we are working with an initiative named Integrated Model in Maternal and Neonatal Health that have 3 components. The community is the most strong we need to work. Health facility nets and health management in municipalities. But we must work with some evidence. And we know that if we work improving family planning, if we work promoting skilled attendance at delivery with women and newborns, and we improve emergency obstetric and neonatal care, we can make the best actions and with evidence. And we can work with the famous 3 delays associated to maternal mortality. The first, at the community, we are working strong with community mobilization, birth preparedness, and I suppose improving the first aid with TBAs, with volunteers, many types of volunteers in our country, and trying to develop communication and transport systems. By bike, by motorcycle, by boat, by plane, say, or a 4x4 ambulance. If this women or this newborn that has a timely recognition of its state of emergency arrives timely to a basic emergency obstetric and neonatal care, or if in the middle we have maternity waiting homes, we can work it out and we can help this mother or this newborn. If our basic among facility don't has the enough skills, we can work to arrive to another comprehensive among facility. We are trying to organize our country, but not only with the community and the services, but promoting health management in municipalities. It's the third point, and I think the most important, but because if our authorities can be sensitive and can invest in health and can invest in food and can invest with all the insumes, drugs, and the human resources we need in our services, because they have the money, we can improve our system. This is an example. It's a department at the north of our country. It's Pando, and it's a municipality. It's called Sena. It has many rivers, and we have a plane airport, and we have many boats to transport women and newborns, and this all of these primary care facilities are articulated, are with communication. If they don't can resolve these emergencies, we have 2 hospitals, more far, but always I think, by land or by water, we can arrive to solve these emergencies. We're working with community birth preparedness. We have here some examples of the way we can make some pictures, images that show women or families about danger signs. And we need to consolidate among implementation. We need to improve quality of care, its continuum of care. We are working in improving reference and return system, involving social needs in self-care and timely seeking for health assist, and finally promoting communication for behavioral change. these strategies are working with care, and we hope we'll have a success result if we work with the community, if we work with the authorities, and with our providers, health providers. And the last and the most important thing, I think, we must work in respect. Providers must respect the human rights that assist to every woman. For example, to elect the position for the delivery, for be with company during labor, or anything that she wants. If our services can work with the providers, and we are trying to do it, I think we can have more success. Thank you very much.
Okay, our final speaker is Dr. Patricia Bailey, who is Senior Technical Advisor at the AMDD program at Columbia University and a Senior Scientist at Family Health International.
And which one is it? I'm going to summarize the strategies and recommendations that came from our one-day meeting yesterday. And much to our surprise, at the end of the day when we had some reflection, there was quite a considerable consensus about what we thought were the highlights of our day's talk. And they were these 6 different topics: multi-sectoral collaboration, mobile phone technology, public-private partnerships, referral for newborns, indicators for referral, and sharing evidence. Referral has been called an orphan cause, and by Susan Murray, she has said it's underdocumented, under-researched, and under-theorized. And we spent a little bit of time amongst ourselves sort of asking, well, why is this so? And one of the theories was that it's everybody's responsibility and therefore nobody's responsibility. Now we know that the referral system, to function well, has to be responding to a continuum of care from home to hospital, and it requires inputs from many different government ministries. Health in particular, finance, roads and transport, and others. I think like most systems, the referral system is extraordinarily complex and sometimes rather daunting, and I think the 3 presentations we've just heard alluded to many of these complexities. We have to worry about financing at the community level as well as at the national level to maintain these fleets of ambulances. We have to worry about the appropriate modes of transportation, whether we're having walking paths or highways, or whether we're trying to navigate rivers and mountains. In the presentation on Ghana, he alluded to the enormous logistics issues related to the maintenance of vehicles, of buying fuel, of repair, training drivers. We also know that clinical judgment and quality of care are very important factors. We should be tracking patient movements and outcomes to determine the appropriateness of referral, and if we're having too much referral or too little referral. I think also there are a lot of things that are very concrete about referral. Certainly the road systems are, and the vehicles are, and the cell phones are. But what makes the system function smoothly are things that are very intangible. And we also lack good indicators for referral. And there may be some truth to the idea that if we're not counting it, it doesn't get much attention paid to it. But being a little bit more upbeat now. Our first recommendation was a call to greater multi-sectoral collaboration. Many of us in public health and medicine remain rather insular in our own area of expertise. But understanding health systems requires working with a lot of different pieces of the system at one time. Now, this is a list of the primary ministries that are often involved in and are committed to emergency referral systems. We noted that once multiple sectors come together, if you can get them to come together, perhaps to plan together, continuous engagement is critical. And we also need to keep in mind that what's at stake for each different sector can vary. Roads, for example, are more likely to be built to promote business and economic growth than to service a healthcare facility. I think we are all conscious of the increasing reach of mobile technologies. The presentation from Ghana highlighted the pervasive use of cell phones from community health workers on up the system, and yet greater synchronization between mHealth and referral is needed. Cell phone technology can reduce delays in transport and treatment by identifying which facilities might be the most appropriate for referral, as well as alerting the facilities who are receiving that a patient in certain conditions is coming. We've all heard stories of women being taken to one hospital and turned away because there are no beds. Cell phone technology should also enable telemedicine and for triage and treatment. And if that can happen to a greater degree, we can actually reduce the number of referrals that are needed. And finally, I think, as the Bolivia presentation mentioned, the importance of that referral and return or counter-referral. Cell phones would be a much needed instrument to facilitate this counter-referral or feedback. The presentation from GVK Emergency Management and Research Institute of India is an example of a public-private partnership on an exceptionally large scale, but many smaller examples also exist. Public partnerships are often established with communication companies. Vodafone, for example, in Ghana, has allowed free calls between physicians when they're talking business in exchange for advertising on their ambulances. Manoshi in Bangladesh and several Indian initiatives contract with private facilities or with private practitioners to provide delivery services to poor women. They also pay for transport for emergencies and for referral. There are also contracts with commercial taxis, vehicles, and trade unions are another example. So I think we need to remember that there are untapped resources in the private sector that can benefit the public good. This is one of the areas where we recognize there's a gap in our knowledge. Several authors have pointed out the scarcity of evidence of referral on the neonate. And in the context, and we were talking yesterday a bit about sort of what are the requirements and how they vary for mother and baby. And in the context of a discussion about equipping ambulances, we remarked on what we know about the effectiveness of kangaroo care for premature and low birth weight infants, and then questioned the use of specialized boxes for transporting babies. We know that a referred baby is likely to be accompanied by its mother, and if she's healthy enough to travel, she could probably carry the baby against her chest. We also know that of the 4 million neonatal deaths that occur each year, approximately half of those take place in the first 24 hours. But we know very little about the strategies for referrals in this small window of opportunity, particularly for the neonate. This is another topic, an area in which we observed a knowledge gap. We noted that basic standards for referral are lacking, but also recognize that this developing standards will be quite a challenge given how context-specific referral systems are. But assuming that we can develop standards, indicators could follow from those standards. And then indicators would lead us to develop better assessment tools with which to identify deficiencies in the referral system. A wide range of indicators is desirable. They might reflect the availability of key components of the referral system. Also, they should reflect utilization of the system as well as quality and effectiveness. And I'd like to draw your attention back to the Bolivian presentation. Dr. Victor Conde described a study of near misses in La Paz and El Alto, and he made the distinction between the near misses who arrived in a critical state at the hospital compared to those that become critical while after they're admitted. Those who arrived in a critical state did so largely due to reasons related to pre-hospital barriers, or you might say due to a very poorly functioning referral system. The indicator Dr. Conde used is actually an indicator that was proposed at a meeting that I went to not too long ago about cesarean delivery. But it's certainly an indictment of the referral system, and it would be the percentage of near misses who arrive at a hospital in a critical state. Now, one of the difficulties, I think, in developing indicators for referral is that we don't really know what the benchmarks or targets are. I don't even know whether there's a right number that we're looking for in some cases. And finally, our last recommendation was focused on the need to more widely share a large amount of evidence so that it might be better utilized by health systems planners and practitioners. We recommended a pooling of evidence. Since 2006, there have been no synthesis papers of the newer literature, and in that year we were fortunate to have 2. Also, I think we recognize that we have a lot of data that are perhaps less than perfect, but this shouldn't really be a barrier to further action. Or in other words, from one member of the group yesterday, perfection should not be the enemy of good. So just to conclude, I think our small meeting yesterday was a step towards adopting this orphan cause of referral, and it served to move us in the direction of sharing more evidence and experience. And I hope there will be other opportunities in the near future.
Before we open up the floor to general questions, I'd like to give any of the participants who were at our meeting yesterday an opportunity to add or comment or say anything about what Patsy just presented. Anybody want to?
Just a reminder, we want you to use the microphone so the folks online can see it. Kaylee, down here, there's a question?
No,
or
just
comment?
make a comment.
Yeah, so bring the mic down here. Get your own handheld.
Can you introduce yourself, Deb?
Hi, I'm Debbie Armbruster with USAID. One of the things we talked about yesterday was, probably not a huge piece, which was why Patsy, I'm sure, didn't mention it, but interesting discussions about what was called a systems navigator, somebody who actually helped, that link between the transport coming in and the referral systems and getting people in a humane way and seen quickly, to prevent the second delay. I think it was Bolivia. I'm forgetting who talked about having this person, but I thought it was a really interesting concept to be looking at further.
Yes, in the back of the room.
Good afternoon. My name is Armin Fiedler. I'm the lead advisor for health policy and strategy at the World Bank. Someone mentioned the challenge of the stovepipes of different, health programs, and maternal and child health many times in many countries falls in the trap to being just another one of these, vertical stovepipe programs. And we often call for cross-sectoral action. But many times we seem to forget it requires an additional capacity of managers, of leaders within a ministry of health or within the health sector to use the health sector's convening power to bring all these other players on board. Rarely would it be the Minister of Transport who would say, hey, my concern is maternal mortality, let's tar more roads. Or it would be another minister saying, well, governance is really, my key concern. So I'm worried about the Ministry of Health getting the inputs and resources required for certain programs. So in addition to just calling for cross-sectoral action, I think it's also very important to focus on a certain capacity and leadership and convening power inside the health sector to bring these other sectors onto the table and into the discussion, and making sure that we reap the benefits of this cross-sectoral action. And I think we have seen some examples of countries where that has succeeded, but I think it would be very important to focus on that extra capacity of using the convening power from the sector. We need to launch this process, and we cannot expect the others to do that. Thank you.
Other comments, questions?
And I got one from the web, our web audience. If I'm interpreting right, it's a question about monitoring and evaluation and knowing that you're doing improvements with very limited resources. So it's a question actually from Lusaka, from Zambia. How would you measure improvement in transportation referral for emergency obstetric patients, given the low transport resources and I think low general resources in trying to capture the data and know that you're improving? Any thoughts? How do you do that M&E with little to no resources?
We have an expert in the room on Lusaka and referral.
And on monitoring and evaluation, the perfect person.
Marge Kablinski, and I just wanted to ask a question, and that was about the pro-poor policy. And I know that you spoke about it from GVK. I'd like to hear from the others also how you can ensure that the equity gap is not widened but narrowed by the pro-poor policies for ambulances.
Coco, do you want to comment at all on that, or do you want to comment, Subad?
Anyone?
What should we do first?
Go ahead. Take either one or both, or the equity question or the doing M&E with low resources, whichever. And divide and conquer.
Well, I think for Ghana, we have a national health insurance, which is being implemented for the past 4 or 5 years. And coverage is increasingly going up. But the kinds of diseases that are covered under the scheme are not as wide as we thought it could be. The problem we have is that with the increase in uptake of services, we still have that clause that ambulance and referral services are not covered under the national health insurance, some categories. So that is something that we are really discussing and working on. You see the fragmentation in the sense that we have a national ambulance service which is doing something different, and we have the facility-based ambulance services. And when you look at the facility ambulance services, they are more or less monopolized by the health staff. So when there is a referral, then who is paying for the cost of the fuel? Who is paying for the patient, for the staff who is accompanying the patient to the next level? Who is paying for the driver? Who is buying the fuel? Who is paying for the cost of using the ambulance itself? It becomes so huge that, in many instances, then the referral doesn't even take place. Patients just pack and go home. So that is the difficulty that we are facing. So even though there's a proper agenda of health insurance coverage, we have not really gotten to where we need to really address those challenges.
Yeah. Can I make a comment here? First, on the comment made there by our colleague from World Bank, I could not agree with you more. We fully recognize what you are saying, And that is why in our whole system, what we have devised is the whole program comes under the Ministry of Health. It is driven by Health Department, but there are committees made where Home Department, Police, Fire, Transport, Finance, EMS Authority, and many other relevant departments become part of that committee, although it is driven and convened by Health Ministry. And also to have a better coordination between them, the chairman of that committee has been made as chief secretary of that state, so that there are no gaps. So that works very well, and it smoothens the coordination, and the strategies can be implemented in a better manner. Making a comment on what she said, from the beginning we were very clear that there's a huge problem of access and affordability. That is why we were very sure for the program to be successful, this has to be free for the users, so that there's equity. But at the same time, there are thoughts that if the service is for everybody and people who can afford, why should not they be charged? But we've thought the number of people who are using this, if we see our figures also, a large percentage of people are from the rural area, tribal area, and poor people. So even if we charge at this stage to a small number of people, maybe at this stage charging them might cost more than what we get out of this. So that is why in all the states, for 500 million people, anywhere, anytime, 24/7, this service is free. And also as we move forward and we cover the whole of India, 1 billion population, it will remain free. That is what our vision is.
I'd like to go back to the, unless somebody else has a question right now. Okay, sorry, go ahead. Yes, Dwayne.
I'm Doyin Oluwole from AED. Thanks to the presenters. I'm so delighted to see that the tractor ambulance is still existing in Ghana. And just to go straight to the presentation made by India, it's very impressive what you're doing right now. My question is, you provide the pre-hospital care. How did you get government to address the quality issue at the recipient hospital? Because it's one thing to get the patient through the second delay. It's another thing to make sure that the care that is required at that center is available. And you're now covering almost half the country. What has happened to care at the recipient center?
That is really a challenge, and the whole system is started with awareness. There's a lot required to be done in providing service and adequate medical help to people at large. We thought perhaps most important area is area of transportation and access to healthcare, and that is why we started intervention in this area. By providing quick transport, good pre-hospital care, we also put pressure on the government facilities as well as private facilities to respond in a similar manner. Not only that, since we are handling police emergencies also, we have seen wherever we have worked, police response has also improved. You might be surprised to know, in the area of animal care, they took examples from us, and they said we want to respond for the animal care also the way 108 is responding for human care. So by doing that, we are putting pressure on the systems to respond according to this. That is one. At the same time, as I discussed with you, we have made monitoring and coordination mechanisms for the program where different sectors, and also this I talked about the state level. We have coordination mechanism at the district level also, where there are committees of chief of health, chief of police, chief of administration, and other stakeholders. We take up these issues of services wherever they arrive. We work in close coordination at day-to-day basis, get them sorted out. If it doesn't happen, we escalate at the district level. Still it doesn't happen, we escalate at the state level. And we have seen results happening. They being aware that if a private partner is able to provide, I must also do it, because ultimately it is for the society. That is one. Apart from that, the gap of infrastructure, gap of human resources, that also we have started identifying, and there also we are moving with partnership with governments to address to those needs and handle those situations and those this thing in a more appropriate manner.
Other questions? Yes.
My name is Abdulhadi Tahir. I'm from Pathfinder International. I must say thank you so much for wonderful presentations. There are so many lessons to learn from these presentations. I'm very impressed by the GVK program. It seemed like very promising, especially for India, like a huge country with a lot of diversity. My understanding is that one of the states in India is very close to achieve the MDG 5, that is in the south, Tamil.
Tamil Nadu?
Yes, Tamil Nadu. And then you mentioned there is like progressive reduction for the maternal mortality, 20%. That is a huge reduction in very short time. And is in the 9 states that you are working in, or is it in one of the states and looking at it one at a time? Thank you so much.
One has to understand that we started this project in 2005 is Andhra Pradesh, and second state in 2007 in Gujarat. All states have come after that, and they are in different stages of expansion. Specific study which I was referring to was done in a state of Andhra Pradesh, but our assessment and preliminary findings indicate that across the states where the service is available, it has maternal mortality rate has reduced to the tune of 20 to 25%. Now, when you are talking about Tamil Nadu per se, recently we have launched 150 additional ambulances in last 1.5 months in Tamil Nadu, and this point of time we operate more than 550 ambulances in Tamil Nadu. So that kind of expansion and those things are happening, and that state we are operating less than a year. So we are very confident, and our assessment shows that that kind of improvement has happened, and when we do the study, specific study, exact results will be seen.
Yes, Pavitra.
I think I'll just being a bit of a party spoiler, but I hope Subodh will excuse me for that. I think we only to say that in India things that are happening, I mean, it's not simplistic to say that only one referral transport has made a difference. The maternal mortality has been falling. The last estimates we have are from 2004 to 6, where and it precedes most of the initiatives that started somewhere in 2005-6. A large thing, I mean, a lot of things are happening. There is an increasing expenditure on health. There is a conditional cash transfer for institutional deliveries, which has increased the institutional delivery rates by from somewhere around 40% to almost 70 to 80% in some of the worst states. I mean, not the higher performing state, but in some of the worst performing states. There is a huge health systems improvement in terms of having improved infrastructure, improved funding, and more flexible funding at different levels of healthcare. On top of that, I think, we have to see the location of the referral transport within the context of health system strengthening. increasing investments on health and increasing focus on maternal health through a variety of demand side and the supply side interventions of conditional cash transfers as well as health systems improvement. In such a context, referral transport by linking the demand and the supply seems to have improved things quite a bit. In terms of the models that operate, I mean, the largest ones are the statewide, what Subodh mentioned about, and has played a huge role in improving the responsiveness of the system. I mean, there is no public service in the public, not only the health, but any public service in the country where the poorest of the person could make a call and there is a response at the doorstep. So that has definitely contributed quite a bit to improving the image of the system, of improving the responsiveness of the systems. But it is located within a context where there is an improving health systems as well as improving demand for those services. The three, we did a review recently, 3 kinds of transport services that are available. One are the large scale, statewide, high technology, and extremely efficient and responsive services that Subodh mentioned of and manages. The other are which are more district managed and the district health societies and the district managed and district owned kind of services. And coming to the point that, besides those 10 states, there are some states which are going in for a district health system managed district, but taking some of the important elements and lessons from this model of having a call center, but at a much smaller scale and a lower technology, but of course not as efficient, I would say. And then there are in some of the most difficult districts, there are some community managed models, small scale, but where nothing else works and there are absolutely difficult roads, and there is an issue of last mile coverage in all of them. But the community managed models seem to be responsive, but again, the problems of scaling up, problems of inappropriate quality or care during transit, etc. remain. So I just wanted to put that in context.
Absolutely right. What he is saying, I don't differ with that. There are many interventions which in our country have been taken. But the point here is, this is one service which has accelerated that process and consolidated everything and pushed everybody to work more towards that end.
Other comments or questions? I'd like to just go back to the question of sustainability that we heard about from some of our presenters. And I wonder if Pete or Gary, one of you people from the transport sector, would like to make any comment about what you may have learned about that issue from your work on the ground, about the whole issue of fuel maintenance, et cetera, parts. You can both say something.
Okay, thank you. Gary Forster from TransAid. For the last 10 years or so, we've been sort of pushing the message that putting vehicles into unmanaged environments is not going to work. It's not going to lead to sustainability, that fuel and maintenance costs often exceed the capital cost of the vehicles within 3 years of their operation. So I think that a lot of donors are coming around to understand the importance of managing vehicles. So yeah, that's our experience. If it's not dealt with proactively, it won't happen.
Yes, I think it also addresses the situation that there's no point referring a patient to a facility that can't cope with it. So,
introduce yourself, please.
Sorry, yes, my name is Pete Sonderscore from the Ranger Production Company. Our involvement here is actually based on the product that we have designed and developed over the last 10 years, which is a motorcycle ambulance, which is designed particularly for a referral situation in a rural setting. The experience that we've had with the people that we work closely with is that the best results are clearly gained from putting a vehicle in a situation that's managed very well. We have been approached by smaller charities. We have actually declined to sort of help them in that respect or give them a vehicle, because it's just not going to work, because there's no point referring patients to facilities that aren't going to be able to cope. So it has to be a continuum right across the whole process, from pickup to delivery and beyond, and taking them home. It's transport that we're talking about, which is, of course, is transport for maternal cases, transport for neonatal cases, transport for every aspect of a medical emergency. And that's what I think we need to sort of occasionally take a step back and look at.
I wonder if you also wanted to share the story of Tanzania, because I think it addresses what you're doing in Tanzania, because I think it addresses this question of intersectoral collaboration a little bit. Right?
Yes, certainly. In 2007, we were at an exhibition in London, Women Deliver, and we were approached by a representative from the Tanzanian government who came along. And I remember the look on his face when he saw the vehicle. It was almost, it was like, it was a eye-opening experience for him. He looked at it and his just jaw dropped and said, "That's what we want. That's going to work." 4 years later, admittedly, it's now come about. So Tanzania have just taken on board initially 420 vehicles, but they're incorporating that into a massive program of healthcare improvements. But they're taking the issue of transport extremely seriously. They're making that a top-level priority. It's referral transport, not just for maternal mortality cases, but it's for patient care with a focus on maternal mortality, and that does help because it's easier to measure the results of that. So we're very pleased to have gone down that journey with them, and they just actually last week ordered another 400. So their commitment is absolutely solid. They know that this is going to make a massive difference.
And how many ministries had to be involved during those 4 years?
Well, you can imagine the decision-making process was quite extensive. I mean, anything that takes that long has got to have gone through a huge amount of discussion, a huge amount of evaluation. The gentleman from Tanzania came down to the factory. They had a look at the production process. They went to Malawi. They reviewed it with Malawi, who also operate a similar program of about 250 motorcycle ambulances. So they had to bring on board the transport ministry, the health ministry, and the Ministry of Infrastructure. So clearly their decision-making process has been time-consuming, but been very effective. They have made a decision. They have gone out, got the funding, and arranged all of that. It's taken 3 to 4 years, but they've made it. What we need to do now, I think, is to consolidate that learning experience and actually put that into a shorter time frame. It shouldn't take this long. There's an awful lot of deaths, unnecessary deaths that have taken place in that intervening time. We've got to narrow that down. We've got to help people make that decision quicker so that we don't have to spend the same amount of time relearning the same lessons.
Sure.
Can I respond to the question from Lusaka? If I understand the question correctly, it was how do we monitor and evaluate referral projects in low-resource settings. I think a valid question following yesterday's deliberations, where we looked at a number of projects that have been undertaken with looking at the management of government fleets, looking at systems like the e-Ranger from these guys, looking at community projects that TransAid have undertaken. One of the questions could be, how do you monitor and evaluate referral projects when you actually do have resources? And I think it comes down to that indicator question. What are we actually measuring? What tends to happen in our experience is the transport people will start measuring transport indicators like the cost per kilometre for moving a vehicle, or the maintenance that vehicle requires, or the distance, whilst the clinicians and the public health people are looking at health outcomes, and rarely the two ever mix. So I think it comes down to this issue of, okay, there are some great things being done and we'd love more integrated referral projects to be undertaken so that we can fill some of these evidence gaps. But I think we also have to have a concerted effort on developing holistic indicators which will show the efficacy of the entire referral system, not just the transport component and not just the quality of care component.
Could I add something to that? I think that one of the places that I would begin would be with the health system and find out in facilities what some of the key components are missing. Surely transport is one. Communication is another one, and that's something that can actually be acted upon in a fairly short-term measure. I would also, if you're at the facility, I would also look at the availability of protocols. Do staff understand when it is that they should refer? given the signs and symptoms that someone is displaying. I would then begin to track some of the outcomes and maybe do sort of aggregated case fatality rates and compare case fatality rates for women who were referred to women who were not referred. And I would also maybe introduce audits, simple criterion-based audits to actually improve adherence to those protocols. So those are a few of the things, and maybe Susan Murray would like to add more.
I'll let you add to that, and then I'll ask my question.
Yeah, the reason I'm being asked to add to it is because I had the privilege a decade ago to work with colleagues in Lusaka, from Lusaka District Management Board, precisely on looking at how we might monitor referral. And Lusaka was, at that time at least, a fantastic place to do it because it had a much more organised urban health system with a very small private sector at that point. I can't comment on how it is now, but it had a system where there was a lot of recording of data going on. It had ambulances, it had radio systems, and one could actually track women's progress through that system. You could actually audit notes, although, of course, the kind of information that's recorded is quite variable. But it was possible to look at a variety of indicators which said different things about different parts of that referral system. I think it's unlikely one's going to find one indicator that will somehow flag up what we need to know and to measure. And, I mean, Patsy, you've said some of the important things about what we looked at. And certainly if you use the partograph in your labour care, then you can certainly look at whether decisions were taken when things started to go wrong or not, and where ambulances called and referrals made at the right time. I think other case fatality rates certainly at the receiving institution. Fresh stillbirth rates possibly is another way of looking at the quality of labour care that went on. But I think it has to be very much location-based. I think it depends on the system. It depends what you've got in place, what you're recording and so on already. I don't think it's something that one can recommend for universally across all sorts of settings. But it needs more work and it needs more imagination, I think, than we've applied to it so far. Thank you. Oh, sorry, Susan, King's College London, sorry.
Hi, I'm Carolyn Curtis with USAID. The question that I wanted to ask is what is in place to ensure that there is appropriate referral to the appropriate facilities? That's just something that's come up in terms of ensuring that the third delay does not occur because perhaps that facility is not equipped or able to manage the complication that just was presented to them with that new referral. So I'd be interested in hearing what's happening with that.
Want me to answer? Okay. In our ERC application, we have hospital information system also. So we have mapped in the geography where we operate all the government facilities and also private facilities we enter into MOU with. The MOU is basically to provide free primary stabilization of any victim or patient we bring into that facility. Now that database is available in the system as soon as any emergency comes, and there is an interaction between the EMT and emergency response physician where the patient is to be taken, decided on the basis of appropriateness of that facility, the distance of that facility, and the third criteria is choice of the patient. If at almost the same distance 2-3 facilities which are appropriate are available, then we give choice to the patient to decide. If patient wants him to be taken to 100 kilometers where a facility is available only at 5 kilometers, we may not agree to his choice. So basically, the starting point is appropriateness and nearness of the facility, and then choice of the patient.
I have a question about the community level. I think both the Bolivia presentation and the Ghana presentation stress the importance, especially in more remote areas, of the community role in organization and really being the first level of referral. And yet we all know of a lot of examples where there have been some very successful examples of community organization and participation in referral networks, but we also know about a lot that didn't last and weren't sustainable. And I think we've talked about sustainability from the side of transport, but then there's this big organizational piece that also is critical, and the integration of the community level into the system. Often the community isn't regarded as a piece of the health system. So I was wondering if you could talk a little bit more about what we've learned about that, what's successful, and how you get beyond the sort of project term successful example to something that's more sustainable over time.
I think it's so difficult. We were working many years with community organizations, but our promoters are not sustainable. Many of them are 1 or 2 years, and they go out, and we must begin again. But in the example of Bolivia, Bolivia has a culture of a community organization, and I think it's so important. And we can now we have a government policy. Its name is Family, Community and Intercultural Health System. And like a policy now is working with every level, with the community and with facilities, because it has two models of work: a model of municipal gestion, management, and a model of health assessed. In the management model, we begin at the community, trying to seek all of the needs and demands of the community that are so diverse and different if we look at the highland, valley, or the lowland, and poverty of that people. But these demands, if these demands are working with this organization system, can go up until the authorities, and our mayors, by law, are trying to respond timely and with opportunity to these demands. I think that if this answer, this management answer, can respond to the community level, it can be successful for everyone. And this demand goes up to the health facilities. It's also an interesting mechanism to demand quality of care. And our providers are working with the community. Communities making social control into the health facilities. And the organized community is working with providers to look for the best way to attend women, men, newborns, and childs. And I think this dialogue between or among community and providers, and if we work with authorities, we can coordinate, we can improve a dialogue that can, I hope, gain some successful and a better attention, a better assist and quality of care, and improve maternal and child health.
I just want to say that I think Ghana, the CHIPS program, has one of the successful examples of community engagement. In actual fact, you cannot launch a CHIPS clinic or zone without the community involvement. It involves a lot of community entry, a lot of community engagement. And if the structure of the community organization is not there, vis-a-vis the village health committees that supervises the work of the CHO, you cannot launch CHIPS. So a lot of the initiatives that are happening within the CHIPS process are coming from the community. And this process is done such a way that they take ownership of health delivery. The CHO is responsible to the village health committee. And so he or she has to present her report quarterly. This is the number of malaria cases seen, this is the number of women we referred. And in terms of referral, it's the responsibility of the village health committee to do that. So those are the kind of structures that are working within the CHIPS process. That we also don't go, within the process, you don't also select your own volunteers. There's a community that will come and appoint somebody to be the volunteer. So whatever you are sending to the community, whether it's a bicycle, whether it's a kit, whether it's given to the committee to supervise over the community. And so in terms of engagement, in terms of transportation, referral, they are really, really working very well. And I think that's one of the success of the CHIPS program that we have seen over the last few years.
I'd like to add something here. Although the program which we run is not managed by community, but we cannot undermine the role of community and their involvement in the success of the project. Recognizing that, we also run a module, a component of the program which we call VOICE. It is volunteer in case of emergency. Now, in Gujarat itself, we have 8,000 registered volunteers who provide different kind of support in attending to the emergency. It can start from sensing the emergency to providing ambulance locations, ambulance shelters, to doing some kind of, if a tire is flat, making that good, helping at the scene in crowd management, different kind of things. So there is a huge involvement of community, community, and not only that, there has to be involvement of all stakeholders in a massive initiative like this.
Okay, we have time for one more question or comment. Okay. Deb, you can have the last word.
It's not really the last word. This is to Carolyn, actually, because I was hoping Victor was going to speak up, but we had a really interesting conversation yesterday. Victor was in, and Patsy, and there was actually a number of people, but Victor gave the rather sad story of the ambulance that went from, you found this out with a verbal audit, or with a maternity mortality audit, went to 4 different hospitals getting turned away, and before she got to the last hospital, the woman died. And all of us were talking about, geez, this mobile technology, could they call? I mean, I think sometimes just thinking outside the box, I mean, probably none of these, that's not how it worked there. Nobody called ahead, but just in order to make these systems work, trying to think out of the box, and that's why we felt the link to the mobile technologies and what a far reach that has now may be a way to think about it. Patsy brought up, though, about was Ethiopia and another country that actually have the Ministry of Health sitting down and talking about referral systems. Which clinics should be referring to what, to what hospitals, and actually creating a system and then informing people. If I got that right? And there was another country, I don't remember that. So there are countries that are thinking about how to organize this so it's more effective. So I think we have a lot to learn, a lot of people thinking and trying things, but I think think there's things out there going on we don't know about, but there are things happening.
I'll share my experience on this. What we have done is, particularly if I talk about cardiac-related cases, so from the ambulance itself, using GSM technology, the ECG is transferred to emergency response center, and the physician at the emergency response center starts giving medical direction to EMT before the patient reaches to the hospital. And in a similar manner, our EMTs are assisting deliveries on the medical direction of physician in the emergency center using GSM and mobile phone only. So that's the way out.
Okay. Can we have one more? Okay, one more.
Okay, I have the chance for the last one.
The last word,
I
yes.
think one issue that we discussed yesterday about is also integration of the whole picture, not only thinking about only emergencies, because when we talk about referral and transportation, we also mentioned that we need to make sure that we're talking about universal access to reproductive health. And particularly family planning. We are now talking about things after the fact, but we can prevent a whole lot of all this happening by making sure that adolescent girls are having access to family planning. And I will be very, very thrilled when GVK will integrate to their services those family planning issues about violence against women, and so that those are also emergencies. And when our exemption fees policies in Ghana, in my own country, will integrate those kind of issues, I think we will make a lot of progress. Thank you very much.
You will not be surprised to hear that is Senan Houghton from UNFPA. Thank you very much. Thank you all very much for coming. Thank you very much to our speakers, to the Woodrow Wilson Center, and our next event will probably be taking place sometime in July, and we hope you'll all come back again. Thank you very much.